I would like to introduce our panel discussion on lessons learned. I am really looking forward to this session, and I am so honored to introduce our highly regarded host for this segment. You thought my hosting was amazing. Just wait, he's going to blow your hair back. Just give me a moment. I've been such a huge fan for many, many years, so. Many of us here follow health reporter and columnist Andre Picard in the Globe and Mail. Andre is an 8-time nominee for the National Newspaper Awards and past winner of the prestigious Michener Prize for Journalism. Andre was named Canada's first public health hero by the Canadian Public Health Association. He is an author as well. When does he have the time? Including his most recent book, Matters of Life and Death, Public Health Issues in Canada. I am honored to introduce and welcome our esteemed panel host, Andre Picard. Hello, Andre.
Hi, Chris. Thank you for the very kind words. Overly kind introduction. Thank you. So welcome to our panel, Unplugged, a panel discussion on lessons learned. As you all know, the purpose of CPSI is to advance a culture of sustained improvement for safer healthcare. There are various strategies to ensure safer healthcare. Now, one of them is to undertake projects such as the Safety Improvement Project, and it has 3 aspects. The Enhanced Recovery Project, which focuses on better outcomes for surgical patients, looking at colorectal cancer surgery in particular. Number 2, teamwork and communication, knowledge translation and quality improvement approach to solving problems, especially local problems. And thirdly, medication safety, focus on decreasing admissions, especially for the frail elderly, who are very common patients in our health system. Now, there are 19 teams across Canada participating in one of these projects that's ongoing. So the purpose of today's panel is to share some learnings from these projects, to demonstrate to other teams what works and what doesn't. What were their outcomes? What did they do differently, these successful projects? And it should make for a very insightful discussion. Now, don't forget that there's a Twitter live feed during the panel where you can follow along and you can share your feedback. Be sure to tag the CPSI. Their Twitter handle is patient_safety, and use the appropriate hashtags depending on what issue you're addressing. Hashtag MedSafety, hashtag ERAS, E-R-A-S, all caps, hashtag Team Steps Canada, steps with 2 P's, of course, and the big one, hashtag patient safety, the overarching issue that we're discussing. So without further ado, let me introduce our panelists so we can use all our time for discussion. To discuss Enhanced Recovery Canada, we'll be joined by Jonathan Simard. He's a management practice consultant with the Operating Room Professional Services Directorate at Hôpital de Saint-Georges in the beautiful Chaudière-Appalaches region of Quebec. To talk about teamwork and communication, we have with us Dr. Deepak Manhas, a neonatologist from the BC Provincial Health Services Authority. And finally, on medication safety, we'll be joined by Dr. Lavo Fernandez, Director of Director of Pharmacy, Clinical and Operations at University Health Network in Toronto. So welcome, everyone. We'll see them appear magically and virtually on the screen before us. There you go. Thanks for joining us. And there's finally Deepak. Thanks for joining us. So let me jump right into the questions because I know there are going to be a lot of questions from our audience as well. I want to know from each of you, what was your greatest aha moment? You were doing these projects. When did the light go off and you said, this is really important? So let's start, Jonathan, with you. Tell me your aha moment.
My pleasure to be on this panel. Well, despite the support of the direction committee and the enthusiasm of the clinical team, we did not receive support from the project office for the organization and deployment of the project. The clinical timing was there. I will now say readiness. So me and Lynn took charge of it. Therefore, we implemented ERAS after 9 meetings between the end of June to beginning of October. And yes, it was during the summertime. So, our first ERAS patient was on October 28th. And we could not have seen it as, we could have seen it as an obstacle and wait, but we turned it as an opportunity, and it's now part of our success.
And what was there a moment where you said, "Ah, this is going to really work"?
Well, you never know what can happen during a project, but I think me and Lynn and our physician champion, we were really together, and we were all the time talking and sending information between each of us. So I don't I don't know if we knew that it's gonna be like successful like this, but we know for sure that we had some skills from previous projects. So it was we had great success. So it's
Great.
really.
Well, we'll come back to some of those issues with the other questions. Deepak, what was your aha moment in the project?
Yeah, so there were a group of us, about 4 of us, who took the Team Steps Master Trainer course. And when we were doing that, we were working on an issue with situational awareness in our site. And there were these periods where we were like, oh, that would be amazing. Or if we implemented this or adding that in, wouldn't that be great? Wouldn't that help solve our problem? And as core people, we had decided on a few key interventions that we wanted to try to implement in here. But we were also nervous about saying, okay, well, we are going to do this, and telling groups to implement those sections. What we ended up doing was getting a group together, an implementation team, lots of people from different backgrounds, frontline people, and we presented the problem to them, and we actually presented them a lot of the material from Team Steps and went through, like, this is our toolkit of things that we could do. And our aha moment was when they picked those same 3 key components that we had picked ourselves. And we had thought, okay, this will make that huge difference for us. And seeing them identify that as the need for themselves was that moment where we're like, this is going to be successful.
And what were those 3 keys that they and you identified?
Yeah, so one of them was using Espar. So that using Espar for communication and having a standardized way of utilizing that. If Espar wasn't having an effect, using some of the escalation terminology. So the 2 challenge rule is repeating the question in case it wasn't heard, and then using some of the cuss terms like I'm concerned about this as a stop the line for that, and then having a proper escalation pathway of a clear line, so there's not questions of who do I go to for help. Sort of were our 3 key categories for addressing the issues.
Great. And we'll come back to some of those tips a little later, hopefully, as well. So Lavo, what was the aha moment for your team?
Yeah, I think the big thing for us, it obviously should always be obvious, but the patient voice is really validating. So what we were finding was what the patient priorities were sometimes really aligned with the actual care gaps, whereas healthcare professionals, we underperformed. So we were looking at things like patient medication education at hospital discharge and something called medication reconciliation, where we're accounting for all the changes in hospital. So those were big priorities for the patients, but it didn't always align with what the healthcare professional priorities were and resourcing were. So I think that was a big aha moment for us. And I think reminding ourselves that we're also all patients. We are caregivers, family members as well. I think taking that perspective makes some of the patient input much more meaningful.
And how did it change your approach to the project when you realized, hey, doctors and patients don't always think to have the same priorities?
Yeah, and I think when we're struggling with low percentages of some of these activities happening, maybe 10 or 20% of patients getting it versus maybe higher than that, I think it meant a lot more to the healthcare professionals that the patients were really trying to encourage us to do it versus perhaps us as administrators or leaders asking them to do it. The patient voice is much more powerful.
Okay. And that, of course, we'll come back to the patient voice a little later because that's a very important component. Now, Jonathan, I want to ask you as well, what would you say, what's the most valuable component of the safety improvement project overall?
For us, it's the ERC clinical pathway, and I thank you to Enhanced Recovery Canada, because we didn't have to do all the research and look to all the studies and reach a consensus. ERC did it for us. It's a huge time saving for a project. And but I also cannot ignore the notoriety of CPSI, which gave us a lot of credibility to the project in our organization. And also a huge thanks to our physician champion implication. I think it's the most valuable components.
So it sounded like you had a template in place that made it easier to get started.
Yeah, well, we had to implement different items, and you know, there are so many studies in the world, and which one came first, and some studies just reach one aspect of ERS colorectal. So ERC just put it all together, and it was so easy for us, and we didn't have to, you know, to talk talk and have a lot of meetings. We just took it and said, okay, the the Canadian surgeons leaders said this, and we did it like easy like this.
Yeah, it's good when everyone doesn't have to reinvent the wheel, that the work's done ahead of time.
Exactly.
Okay. And Deepak, same question for you. What was the most valuable component you found of the project?
I think I speak on behalf of our team when I say that certainly the COMBI, looking at behavioral change and using the capability, motivation, and opportunities as our fallback every time we encountered a problem. Whether it was looking at what are the what are the barriers to creating a change here, or what were the problems that we were seeing, we were able to map that down to capability, motivation, opportunities. When we looked at the intervention and tried to anticipate barriers and facilitators, we went back to that same model, and we were able to map things to what we saw in our own local setting. And even when we put the education in and the implementation part of it, we went back to that same model. And so when the project did launch, and every project has their PDSA cycles, and you're trying to improve it as you go along, we had that framework to fall back upon, and that really helped us not get overwhelmed and really target what the problem is. Like, we always want to go back to things like, oh, well, just educate them again or remind them again, but it wasn't necessarily an education or reminder problem, and it just helped us deal with the core issue.
So I'm hearing the same thing. The framework really matters a lot.
Yeah.
Lavo, did you have that same experience? The framework helped you work through this?
For sure. And I think another way that we were thinking about it, sometimes we're so focused on the intervention and the content we're trying to do. Really, it's sometimes more about the process. So I think one of the biggest things that it helped us with was taking a step back for systematic reflection, which sometimes we don't always do. We jump right in there. And I think what helped us were participating specifically in the sessions on implementation science and change management. I think it inspired us, and I think refocused our efforts in what we were going to do. So, for example, something of just sharing data with your healthcare professional team, how do you do it in such a way that it motivates them and inspires them versus demotivates them? Because sometimes it could be negative data. So really getting their input into what should it look like? How often do you do it? So I think taking that step back and focusing on process rather than just the intervention was a huge help.
And talk more about that idea of systematic reflection, because so many projects are just focused on outcomes. You don't stop to think very often.
Yeah, I think so. Taking a step back to really think a little bit about maybe just having some focus groups of the key healthcare professionals and patients as well, to understand what are the barriers and the frustrations they're having, and then getting that group of stakeholders to think about what those facilitators are going to be, rather than, I think sometimes we on the outside think we know what the answers are, but just really engaging the healthcare professionals and the patients in the process.
Right. Now, Jonathan, this learning collaborative has ended. So I want you to look back and reflect on what would you do differently to implement change based on your experience? So what's the big thing that you would do differently?
Well, the learning collaborative we didn't learn how to manage a project, but but this helped us to get people to behave as expected. So we had an exceptional implementation in the Hôpital Saint-Georges with a dedicated team, and we are proud of the results. But with the COMBI, me and Lynn, we were doing situation, and we were saying, if this happened, what we're gonna do. So we took the COMBI and as a way to be prepared if something happened, And this helped us to be ready if we had to intervene more precisely. Yeah, and we also use knowledge from previous projects and added a bunch of activities like Bono 6 Thinking Hats as a retrospective activity. And we also have designed a mapping of clinical path following this project, and which will be practical for our next project, along with also an activity tracker. So yeah, that's it. Yeah.
And you mentioned Lynn. Lynn Picard has joined us, but she's hiding behind the camera there, so we can't see her. But want to thank her for joining us. Oh, there she is. Oh,
yeah.
Put her in the spotlight. But go back and tell me one specific thing that you would change if you could do it today in retrospect.
We'll do it faster. We were. You know, we implement during summertime. I think we did a great job and a lot of adaptations, but everything went smoothly even during summertime. So we didn't implement before during COVID. We already implemented it. So, but during summertime we had to make a lot of adaptations with our schedule. People are being during summer, so. In vacations, and but I think everything went very smoothly during summer. But I don't know, maybe the last part we could go faster, but you know we were doing it with a lot of other responsibilities. So I think I won't change. I don't change anything if I do it again. I think I'll do it the same way. Yeah.
Okay. And Deepak, you know, they say hindsight's 2020. What would you do differently in retrospect?
Not do it in 2020. No.
You shouldn't do anything in 2020, yeah. I think.
I think for us, one of the things that we knew going into the project that we were going to have a little bit of a struggle with was really our metrics. And we were doing this big change, a big behavioral issue, and how we were going to address that. We wanted to have our metrics down and how we were going to audit the process. And we thought we did a pretty good job with it. Going through the project and getting through the completion of it and actually working on that metrics, I think having spent a little bit more time, we thought we spent a lot of time on that, but I think even taking that detail out, talking to other people to really push us, to force us to be able to answer those questions, put us in that uncomfortable zone to make sure that it's completely ironed out, I think would have helped with the auditing process as we went along the way. Because these kinds of things, when you're doing big projects like that, if you have something that you can clearly measure, there's parts that in retrospect were certainly easier to measure, and other lofty goals and ideas that we had that we wanted to see change. And those are much harder to measure. So how could we have found better metrics to come close to measurement of those, or give us an idea of a change in that direction?
And you talked about the uncomfortableness. How important is it to get out of your comfort zone sometimes in these projects?
I think in these projects, that's what pushes the conversation. That's what makes it takes it to a higher level. Whether it's with sponsors or frontline staff, having to discuss the fine details of it, how it's going to impact people in their day-to-day life, makes you think through all the processes of it to make sure you don't miss details. But it also generates that conversation to have new ideas come forth, and that creativity and thinking outside the box of like, well, actually, what if we did it this way instead, which is a slight tweak on that, I think really helped us.
And Lavo, same thing. In hindsight, anything you'd do differently?
Yeah, I think just learning from this whole intervention and being part of this bigger group was moving away from a single project mentality. Sometimes we're just trying to focus on one thing, to really thinking about it as continuous improvements and refinements over time. And I think it's like a big experiment that you can be more forgiving to ourselves as a team about when things don't go right, and looking at it as an observer. So I think that was one of the key things. I think we learned a lot about just the combination of strategies we can use to overcome challenges. And it was great hearing from the other national teams that they had similar struggles. So it was validating. So you felt, okay, it's normal that, as my other colleagues just said, that it's not happening at the pace that we want it to happen at.
Does anything ever happen at the pace we want it to?
Yeah, I'm starting to realize that's very normal. No, great point.
But again, come back to, is there one specific thing you would have done differently?
Yeah, I think, again, probably get that patient voice earlier in the process. I think it would have, their statements and their quotes, I think, were very powerful in motivating the healthcare professionals to change. So I think we got that at the end of the state, once we got through the healthcare professional voices first. I think that would have helped.
Okay. Now, Jonathan, you mentioned a couple of times, you know, as the summer, there was COVID. I'm interested on how COVID, you know, changed everything in our lives. How did it change your project?
Well, we already implement ERAS colorectal in Hospital Saint-Georges. So it right now is just we do less colorectal surgery because of COVID, and you know, but all the maybe the thing that we had a bit of an issue is using the measurements and trying to improve the project. We developed like another way to communicate with our physician champion, and now we're talking with them kind of regularly. So, but if I would say during summer, because that was our huge part of the project, we did it during summer. We made adaptation like having less meetings, so people could, but people on the implementation team could add a lot of homeworks to do, and we give them a lot of responsibilities. So every one of them around the table had to do, like, you know, big homeworks, big sometimes small, but they just come back after they did their homework, and we were spreading the information to all the teams. So, and we were helping them. Me and Lynn were helping them, and I think we did a good adaptation of during summer. And I think what we did can be done during COVID. So I think, because, you know, we say we don't start any project during summer because everybody is in vacation, but we did it. So.
And I don't think there were any vacations this summer either, as I recall.
No, exactly. Yeah.
Okay. And Deepak, did COVID have an impact on your project?
Yes, it certainly did. We were implementing our project in February of 2020, and we had just started the implementation, and we were having grounds and educating people and getting buy-in with the project. And then COVID happened, and being an intensive care unit, we really had to step back and put our resources into how are we dealing with COVID. Simple things, even positive protective equipment, and how our resuscitation is going to be different. So all of our resources were then redirected into COVID. Luckily, we didn't have a large impact based on patients and whatnot here, but getting prepared was really great. The nice thing about that was that when we did pause it and we were looking towards COVID and how we were dealing with that, people started asking questions of, how do I deal with this if we actually had some of the interventions that we were talking about and they had heard about because we'd addressed academic days and nursing ed days, et cetera. They were saying, if we had used this, we could have prevented this, or this idea of the project would have made it easier to go through. And so we were actually able to use that to have our leadership help us re-implement the project. So we did go live again in July, so in the summer, and we were able to use that even in the COVID environment. So it was a bit of a delay, a needed delay, but I think that actually even helped us with the project.
And COVID, more than anything, showed us the importance of good communication in the health system. Were you able to feed off that project for the larger communication part of the puzzle?
Yeah, it included having less people around and improving that communication there, making sure that we were escalating to the right people, not just everybody, and also having those contingency plans so that we knew who to have around. That certainly helped in the process.
Well, Lavo, how about medication safety? Was there an impact there with COVID?
Yeah, our specific project, it was actually focused on surgery patients. So as we all know in the news, the number of surgeries, the focus on surgery had changed, especially in March and from March to June. So I think that was a big thing. And I think at that time too, just being at a teaching and research hospital, a lot of non-essential research was paused, including quality improvement activities as well. So I think it was all hands on deck there. But I think the crisis sometimes forces innovation and creativity. So how do we interact with patients virtually? on that. And I think we're all, not just patients, all of us are learning how to use these virtual platforms and phones in different ways. So I think that's where the innovation and creativity, and some days it's more efficient to do things that way as well. So we're still learning.
Well, you all look like masters of Zoom today. It's going off swimmingly. Maybe I shouldn't speak too soon. You never know when a cat will jump in or there'll be construction, but these things keep us on our toes. Now, again, I guess I'll stay with you, Lavo, because you've mentioned this patient voice a few times. And I'm interested in that. How important is it to incorporate the patient voice into these projects? We hear about patient-centered care, et cetera. We know patient voice is really essential in safety. Tell us generally how important is this to make it a priority?
Yeah, I think it's extremely important, and thankfully that's becoming much more, we're opening our minds to that in healthcare in general. I know we're guilty, I'm guilty of not always thinking of that at the beginning. So I think it's extremely important because it is often, as you mentioned at the question at the beginning, it's an aha moment because they have a totally different perspective on things. And sometimes the things that we are doing that we think are improving safety are actually causing risk and introducing other errors. So I'll give you one example. When we talk to patients about information that we gave to them at discharge, we thought we were being very smart. We'd give them a grid of the medications and we'd put an X of when you had to take it. But some patients said that they thought that meant they were not supposed to take it at that time. So I think it's very humbling, but very important lessons.
Now, Jonathan, I saw you nodding yes. How did you get the patient voice, the patient feedback in your project? How important was that?
Well, in the implementation team, the patient voice was extremely important at the beginning because we made our first meeting with the implementation team. We didn't have the patient with us, and people were saying, oh, we don't need patient. We know what we're gonna do, and this thing. No, they don't. The patient don't need it, and when he came in, the patient just talked about that he was hungry after the surgery, and he had no food on his table, and he didn't know what he's gonna do with the plastic thing on his table, and so all the implementation team were listening, and they were just, oh, okay, we said totally the opposite the first meeting, and so everybody went in the same the same path, and we just nailed this project in a couple of months. So that was for the implementation team, and then with the patient on the care unit, they help us to improve and to reinforce with the team, some lessons or some things we said to the team, and when I said that many things went really smoothly, it's just I can't believe sometimes I can't believe that we did it like so fast and so good. So but we're still in improvement. So but the patient is the key, absolutely. Is a key. It's really important to have one on those projects. Yeah.
And Deepak, I'll ask you the same thing. The patient voice in communication is a big element. How did you incorporate that?
Yeah, we were looking at situational awareness and identifying early warning signs and escalating them appropriately early. And parents of their babies are really the first ones who notice that something is different. So we knew that gut intuition that parents feel, that was an important piece to the puzzle. And we were lucky enough to have one of the patient family advisors actually be part of our team to help us with that. And he was able to reach out to different families and get their input along the process. And during it, we actually were able to develop another communication system in parallel with what we were doing with the healthcare staff of allowing ways to have parents actually improve how they communicate with the team and address their concerns and how can they escalate if their concerns aren't being heard, and using some of the ways of getting attention and escalating that. So we were able to do a lot of the same teamwork steps that we were using for our healthcare team to incorporate with the parents and give them their own tools to help them really say, hey, something's wrong with my baby, something is different, we need to take a look at this. So very critical in the project.
Because we've heard that, during COVID, patients have felt that they're left out a little bit because there's all these other priorities, but it sounds like you made an effort to really incorporate them.
Yeah, certainly. And we're the one place of the unit that still lets both parents come in. Most places have one caregiver, and we've been able to adjust to have both the mom and the dad there, and certainly hear their concerns.
Great. Now, Lavo, we've often heard the Canadian health system being, loving its pilot projects, but things never come into permanence. How do you ensure that your project is going to be there to stay, that it's going to have a long-term impact, not just the duration of the project?
Yeah, great question. I think sometimes having government oversight where they're asking us to send in data on health quality indicators over time, it can also be a powerful incentive. So I think that's something like that definitely helps a lot. I think at the same time, though, I think it doesn't not just from above the organizations above us, but really with our peer hospitals across. That's what I really loved about this initiative. You got to learn from small rural centers, from big centers, but across Canada. So we're trying to benchmark. There's about 32 hospitals working together on some of these strategies, trying to learn from each other. So maybe there's some really good things happening. I think it's a good peer pressure incentive that you have to submit data every year, that you can learn from each other and share ideas.
So my hearing is it going to be permanent? What you did is the change going to be permanent?
Yeah. I don't think we have a choice. It will be at least moving ahead. I think it's going, but I think it's that idea of continuous monitoring, and that's the challenge.
Okay. And Jonathan, Hôpital Saint-Georges, is this here to stay? This project you learn from? Are you going to keep doing things that way?
Absolutely, and we're going to improve it, and we're trying to implement it in the other facilities of Discharge. Yeah, and as we said, measurement is the key. Monitoring, and challenging the surgeons. I think it's part of how can we improve it. And patient survey, it's also a key with to improve this project because it's a project as an end, but it's not a project anymore. So we're working on the improvement of this project now.
Right. And Deepak, same thing. Can you move from project to permanent change?
I truly hope so. We have a couple of things that are trying to help with that. We have a quality and patient safety position where we have the person in that position. She's been really great at helping with the auditing and really taking charge of that and making sure that we're seeing when things are slipping and going back to that combi of trying to reintegrate when there's issues. But I think the bigger thing is that it really is that behavioral change, not just in looking at this situational awareness or escalating care for patients, but really how are we integrating it into the culture, into the behaviors, or into just the day-to-day of what we're doing. That the two-challenge rule and asking it again doesn't happen just when you're escalating care. We've been encouraging people in any type of conflict or confusion or discussion via emails or in written form. We're asking people to use Espar. COVID's been a great example of that, where our hospital has actually asked for any requests to be in Espar format. So it's ingraining it in the culture of what we're doing in everything. And so once it becomes that habit that we've been talking about today, I'm hoping that it will persist. And really just making it not about this one project of putting these pieces in, but having it overarching in our environment.
And we do have a fairly broad audience, so tell us briefly what Espar is.
Espar is a situation background assessment and recommendations are in there. And so when there is a concern, being able to be like, this is the situation that we're having here, and you can use it for a medical thing, or you can use it for something that is generic. My light burnt out, the lights are out, and giving the background as to what's going on, your assessment of it's not the electrical, it's just the bulb, and then can you bring me an extra bulb, having that recommendation or the question at the end there, to try and really make all that information that you want not go on forever, but also making sure that the important pieces are there so people can make the decision to move forward or to provide the care to that patient or deal with whatever problem it is.
Sounds like an army thing to me. We need the SBAR team in here, almost like SWAT.
Yeah, it certainly gives a structure and a format there, but I think there's a fair bit of space for people to develop their own.
Okay. So Lavo, you've done this successful project. What's next? How do you get it beyond the walls of your institution to other groups, organizations? Where do you go with it?
Yeah, it's a great question. So one of our biggest care gaps, again, is it sounds like a simple thing, but it's about patient education at discharge and something what we call reconciling medications at discharge. So I think we've formed a collaborative of hospitals across the country of where we can share data and learn from each other. And I think that's the next step to motivate us in terms of continuously trying to improve. But I think really drilling down into, so if you look at many hospitals that are part of it, if there are three that are doing something really well, can we learn from them about how they're doing that really well? And it's very possible other hospitals are doing something else really well, and meeting on a regular basis to do that, and displaying our data, looking at ways we're sharing that information with our frontline clinicians in a motivating way, that they're using their information to advance practice and hopefully improve patient outcomes.
And you're working with such a vulnerable population. These changes are so important. Jonathan, same question. You talked about sharing this with other institutions in Chaudière-Appalaches. How do you make it? How do you get all of Quebec hospitals to learn from what you've done?
Well, we want to shine in our organization first. It can be a challenge. We take it as a challenge, and we for sure want to change few things. But if we can do it, if we can change things in the province of Quebec, well, I think me and Lynn are on it. So, but right now we're more on the Chaudière-Appalaches.
You got to aim higher. You got to go for a bigger audience.
It's a challenge. We can, like, I think we can do anything when we have the room for it. So it's sometimes it's a matter of it can be chance, it can be luck, but it also can be I think a CPSI is a great way to spread that, like what we did in Hospital St. George. It's a small hospital, but it's in Quebec, French, and we're here with CPSI. Everything is in English, and I think we manage pretty well our project. So yeah, I hope it's gonna be on the website.
Okay. And Deepak, same question. What's next? How do you get other organizations to learn from what you've done?
Yeah, so it's been pretty exciting because as we've been working through on this project, there's been spread just through word of mouth. We've had conversations with our maternity colleagues, as well as people who look after healthy newborns, of how we're going to be able to incorporate some of what we've learned here in our neonatal intensive care to there. Also, when we were looking at this project, we had talked to our hospital leadership, and sort of our environment was our pilot project, and looking at the success and the outcomes that we've had here, the idea was to be able to spread it site-wide across the entire hospital. And so the proposal's been in, the funding's there, the funding would be available potentially, and they're really looking at this as a pilot project. So it always had that as an intention. And we work really well with Perinatal Services BC, which actually looks at the care for all babies in BC. And if we were able to get that as a site-wide project for us, I think that it would be a great possibility to partner with Perinatal Services BC and try and get some of the other sites on board as well.
I always get nervous when I hear those words pilot project, because it almost means it's going to be dead soon.
It was a pilot site, I guess. Like, it was to try it out, put the resources in one site, see how it goes. Do we have an outcome? It's certainly, as I mentioned, like it's been ingrained much more in the culture here. So I don't think it's a pilot as a transient thing here. And I certainly see it spreading already just through word of mouth and people asking about it. So I'm quite hopeful that we will be able to take this forward site-wide.
Right. Now, Lavo, all of you are very enthusiastic about your projects. They're all very successful. I want you to speak to the people who go, oh, I've already got so much work, I don't want another project. Sell them on this idea of embracing a project like this in the future.
Yeah, it's great. It's a great question. I think also it's a very realistic question, and I'm not sure I have all the answers to that. I think part of the thing is rather than maybe talk to them from the outside, how do you engage them in it and really show what the patient impact is going to be, and how do you translate some of the key messages, how that can improve outcomes. So some of the things we were talking about, can it prevent a readmission to hospital? So they understand they're impacting, it's not just about data and stats and indicators, it's about how are they improving the patient's lives. So it's understanding that, translating that in a meaningful way, I think is key to involving them, but also really hearing about their frustrations and what their ideas are on overcoming them and incorporating that.
And did your project change patient lives?
You know, I think we're a bit smaller there. I think we know from some other published trials that when they do this in randomized controlled trials, it can, with a bunch of other interventions, reduce something like readmission. So certain professions partnering with the interprofessional team, the patient, who we do know that, so not necessarily mortality, but it can change bigger outcomes like readmissions to hospital, but not us by ourselves. We're a small cog in the big picture.
But every little bit counts. It's all cumulative. Yeah.
Yes.
Now, Jonathan, same question. Why would you tell other people to do a project like this when they already have a lot of work? There's lots going on. Why do you do something like this?
It's a lot of work, but it's a high value project for the patient. And that's what first drives us, me and Lynn and the other, our physician champion. It's a project with only high value outcomes for the patient, and I say, like, go for it. It's not just a project like a regular project. You know, you have to implement a paper. It's not a paper. It's everything. Everything is important for the patient, and that's what we said. Hey, we have to do this. We have to go with the CPSI for this project. We cannot pass beside it, and I will say, like, go for it, and then you have to manage the things around. But yeah, that's it. Yeah.
And you're very proud of your project. It's obvious. Tell me how it impacted patients.
Well, we started with a 4.8 length of days of length of stay, and now we are at 3, and so it's a huge improvement for our hospital. So it saves us a lot of bed on the care unit, and but we did it, and we didn't just put the patient outside of the hospital. We give him information. The patient is now engaged. We don't do everything for him. He knows what he has to do, when, where, and that's amazing. So it's only a high value project for us, and yeah, we were asking us, should we do it or should we change something? No, it's when you do lean management, or you just want to keep the high value stuff you do, and that's what we did with this project.
And Deepak, I'm going to give you the final word. We're almost out of time, but tell people why they should do this kind of thing, embrace another project even though they're busy.
I would concur with Lavo and Jonathan, that knowing why you're doing it, the impact that you're going to have, the educating people on those possibilities is sort of that key thing there. And I think we all go into what we're doing for altruistic reasons. We like helping patients. We want them to get better. We want to see that improvement. And yes, it's a lot of work, but it's really exciting along the way. And we're not doing it alone. We're doing it with a team. Here we had CPSI, but there's other things. At our site, we have new knowledge and innovation. There's quality improvement experts. There's people who work in patient quality safety. So not feeling like we're alone in this, tapping out to our resources and getting that help, because it really is an exciting journey, and seeing the progress is very rewarding.
Great. Well, thank you to our 3 panelists. I think people are going to rush to their computers now and start filling out forms to get on the next project. You're all very passionate about it. So I'll throw it back to Chris to close it out. But again, thanks to all 3 of you.